Good morning, everyone, and welcome to the AMSSM Sports Ultrasound case series. We appreciate everyone taking the time to join us today and later on the YouTube channel. Our speaker today is Dr. Naina Bouchereau-Lal. She is a board-certified family medicine and sports medicine physician at LSU Health Shreveport, where she serves as Associate Program Director for the Family Medicine Residency Program and Clinical Faculty in Family Medicine and Sports Medicine. She is actively involved in medical education across the learner continuum, with particular interest in musculoskeletal medicine and diagnostic and interventional ultrasound. Her sports medicine practice spans collegiate athletics, athletes with intellectual and developmental disabilities, and performing arts medicine, and she serves as team physician for several state, regional, and community organizations. Dr. Bouchereau-Lal will be presenting a sonographic evaluation of a case that comes up commonly in clinic with greater trochanteric bursitis. Before we get started with that, I'd also like to highlight one of our AMSSM educational resources, the Library of Sports Ultrasound Pathology. The library is a growing collection of high-quality ultrasound cases covering both common and uncommon sports medicine pathology. It's designed as an educational resource for anyone looking to expand their ultrasound experience. Keep in mind that any attending or trainee can submit cases. If you come across an interesting pathology with quality images, we encourage you to submit it. If you're interested in contributing or have questions, the contact information is on this slide, and we would love to continue growing the library with submissions from this group. With that, Dr. Bouchereau-Lal, I will turn it over to you.
All right, good morning. Thank you everyone for your patience. We had a little bit of technical difficulty, but we'll go ahead and get started. Thank you for that introduction. So I have no financial relationships to disclose. All the ultrasound images and videos are my own. However, all other images in this presentation are AI generated. So this is a case of a 43-year-old female dance teacher who presented with right-sided lateral hip pain that developed about a month prior to her seeing me in clinic. So at that time, she was in class with her students demonstrating some choreography where she had to really lean excessively into her right hip. And then shortly after that, she developed some symptoms of some sharp, aching, burning type of pain, which could reach a severity of about 8 out of 10, but on average was about a 3 to 5 out of 10. It didn't radiate anywhere else. She didn't have any history of trauma or hip issues in the past. The pain was intermittent, but it occurred daily and often multiple times a day, exacerbated by standing for extended periods, laying on her right side, especially at bedtime, squatting, going up and down the stairs, jumping, and pirouettes. For those of you who are not dancers, a pirouette is a move on one leg where you turn really fast and the other leg is raised near towards your body. So the ultrasound protocol for the lateral hip we'll be talking about today starts with the greater trochanter of the femur, where we're going to identify and evaluate the anterior, lateral, posterior, and superior posterior facets, the gluteus minimus tendon and muscle, the gluteus medius tendon and muscle, the greater trochanteric bursa, also known as the subgluteus maximus bursa, the superficial arch at the greater trochanter, which includes the gluteus maximus, the IT band, and the tensor fascia lata. And then dynamic scanning for external snapping hip. And then finally, there is the option of the proximal IT band origin at the iliac crest. So there are four facets of the greater trochanter, which are primarily used as the anatomical landmarks when evaluating the lateral hip. First, there's the anterior facet, which is highlighted in purple here. It faces anterior laterally. It's the attachment for the anterior fibers of the gluteus medius as well as the gluteus minimus. Then there's a lateral facet in teal or turquoise. It faces laterally completely, and it's the primary attachment for the middle fibers of the gluteus medius. Then we have our posterior facet on the back. It faces posterior inferiorly, that's in yellow. It's the attachment for the posterior fibers of the gluteus medius. And then finally, we have the superior posterior facet, and that's in red on top posteriorly there, so superior posteriorly located, and that's the attachment for the gluteus maximus. So I find this a very helpful diagram to refer to when scanning the lateral hip because it gives us a really nice roadmap and kind of orients us in space and understanding. So once we know what facet that we're over, we can understand where the surrounding tendons, muscles, and IT band should be relative to that facet. Because the question is always, is this short axis? Is this long axis? So this helps us figure out whether we're seeing those structures in cross section or longitudinally based on our probe orientation. So sometimes you can have this kind of just close to you just to kind of refer if that's helpful for you. So this patient's radiographs were essentially unremarkable. Joint spaces were well preserved, alignment was normal, no fracture, no significant degenerative changes, and no other obvious osseous abnormalities to explain her lateral hip pain. So can you all see my pointer on your end?
Yes.
Okay, perfect. So we start the protocol with the greater trochanter and evaluating all the facets. So starting with the probe over the femur and transverse. So I have diagrams of position because I always find helpful to see what the position is versus what you're seeing on your screen. So again, in transverse right here, and you're sitting over the femur. Anywhere on the femur is fine because eventually you're just going to work your way up. So on this video, starting on the femur, which is right here, working our way proximally until we reach this peak right there. And that peak is important because that peak is what separates the anterior facet here from the lateral, or sorry, yes, the lateral facet over here. So again, starting on the femur, working our way up, finding our peak. Okay. So still doing anterior facet. In transverse, the anterior facet appears as a smooth, gently convex hyperechoic cortical surface right here. The bony peak here separates the anterior facet from this lateral facet right there. And the anterior facet is the footprint of the gluteus medius, which sits right here. This photo doesn't really have a good visualization of it, but it does sit here. And if you look at the photo, this is what I'm talking about right there, the gluteus minimus. Okay. So from the anterior facet, we're going to go to the lateral facet. So we're going to move this probe laterally over the greater trochanter towards the buttock. And you'll see the greater trochanter become more convex instead of concave. So this is our lateral facet now, which is the footprint of the gluteus medius in transverse, which is right here basically. Now here you see that the gluteus medius is pointed. So what we want to do is we actually want to rotate the posterior aspect of our probe up by 40 degrees. So now we have a full band of the gluteus medius that's nice and thick, all right? And then we have anterior facet, lateral facet, and here we're actually seeing the posterior or superior posterior facet. Not the posterior, but superior posterior because of the way we've changed our probe to go all the way up here at that 40-degree angle. So once you're able to line everything up and go from anterior to posterior facet, you can start fanning the width of the muscle to look for pathology. This is just a video going from anterior to posterior so you kind of get an understanding. Anterior is on the right, posterior is on the left. So is that concave, convex, and then we're dropping to that posterior here. All right. So next we'll evaluate the gluteus minimus tendon. So using the anterior facet as our bony landmark, again, right here, it's a bit granular, sorry, we can identify the gluteus minimus tendon inserting directly onto the anterior facet of the greater trochanter. So we start in transverse or short axis where the tendon is superficial to the anterior facet. From here, we rotate the probe 9 degrees counterclockwise. So we go from this position to this position to bring the tendon into the long axis. So here it's short axis, and now we're getting into long axis. Our tendon's right there, and you can see how the anterior facet really slopes off over here. So the key is to use the bone as your roadmap. If you know you're centered over the anterior facet, you'll know the tendon immediately is superficial to it, and that should be the gluteus minimus. So after that, we evaluate the gluteus medius. So again, in transverse, identify the posterior facet of the greater trochanter, where we can visualize the footprint of the anterior band of the gluteus medius tendon. From here, we rotate 9 degrees counterclockwise to bring the anterior band into long axis. And then you can follow its longitudinal fibrillar pattern. So again, from here to here. So we have that long pattern right there. And then eventually this will transition into the myotendinous junction and the gluteus medius muscle. And I'll show that here. So there's that muscle there, or the tendon right here. And then if you move, myotendinous junction right there. So next we evaluate the trochanteric or subgluteus maximus bursa with the probe transverse over the greater trochanter again. So finding the lateral facet of the greater trochanter, you're going to identify the gluteus medius tendon inserting onto it. So right here. And you're going to look immediately superficial to the gluteus medius for the subgluteus maximus bursal plane, which is right here. Okay. And then above this is going to be your gluteus maximus with the IT band superficial to that. So you'll see gluteus medius is deep to the maximus. The gluteus maximus is sweeping across superficially, and the bursa lies in the middle here. So if I play this video, you'll see the slide. Okay. So normally this is a potential space, but in her situation, she actually had some fluid in here. Hopefully you can appreciate that. So after that, we look at the superficial arch. The superficial arch is the musculofascial roof of the greater trochanter. That's what it's called. The gluteus maximus posteriorly, the TFL anteriorly, and then it's connected by that thick IT band. So it's kind of just to help frame everything for you. So remember, the IT band can actually be 4 to 6 centimeters wide. I think some of us forget how wide it can actually be. We think it's a really skinny band. It's not. It can be very thick depending on where it is on the leg. So the term superficial arch can make it sound like there's this other structure we need to find. It's not. It's just the characteristic superficial arrangement of that gluteus maximus posteriorly, IT band laterally, and TFL anteriorly. So before we scan, this is a cross-sectional image. It just helps orient what we're actually looking for. So imagine this is someone lying on their left lateral decubitus. And this is a cross-section of their pelvis, and you're looking from the bottom like an MRI. And at this level, you'll see the IT band very superficially over here, spanning the lateral hip. Posteriorly, you're going to have that gluteus maximus, and then we're going to have the tensor fascia lata over here. And the middle, you have your gluteus medius and your gluteus minimus and your greater trochanter right here. So when we talk about evaluating the superficial arch, we're really looking at this superficial lateral soft tissue complex and their relationship to one another over the greater trochanter. So this is the cross-sectional anatomy we're essentially trying to appreciate on the ultrasound in a transverse orientation. So once we identify the greater trochanter deep, we can work superficially and identify the gluteus maximus posteriorly, and then the IT band, and then spanning superficially, and then the TFL anteriorly. So like this. So that's anterior, TFL, posterior, gluteus max, TFL. So our band, our IT band is in here. Okay, coming off that TFL and going into the gluteus maximus. All right. So the superficial arch establishes the relationship of the IT band, gluteus maximus, and TFL over the greater trochanter, and is actually the starting point for a dynamic assessment of the external snapping hip. So for the external snapping hip, you basically place the probe primarily over the lateral facet like we've been doing over the greater trochanter. And the key is that you want the transducer positioned where the IT band and the anterior gluteus maximus complex cross, most prominent lateral portion of the greater trochanter. So for your scan, you'll center over the lateral facet, and you're going to appreciate the lateral prominence of the greater trochanter in the ultrasound image. And let's see. Okay, so greater trochanter, lateral facet. The gluteus maximus is back here. We have our IT tendon over here. Now, in her case, there is no snap, so you're not going to see any snap, but this is the image you should be looking for. So for the final portion of the protocol, we're going to evaluate the IT band proximally at the iliac crest. Again, this is optional depending on what type of case you have and if you need to do this. So what I like to do, I like to scan the IT band at the iliac crest because it evaluates the proximal attachment. It is an uncommon but important source of lateral hip pain that can be missed if evaluation is limited just to the greater trochanter. So before moving proximally, I do like to identify the IT band over the greater trochanter. It's just easy to find usually. So here the probe is going to be oriented in a longitudinal axis for now, and eventually I will turn it on short axis. So here, this is distal, and this is more proximal, and that's our greater trochanter right there. So once I've confidently identified the IT band here, I can use it as a landmark and then track it proximally all the way up towards the iliac crest. I don't have a video of that. These videos are really short clips, so sometimes they don't catch the whole thing, but I'm sure most of you will know how to track that all the way up to that iliac crest. So when I have the IT band in long axis, then I'll spin the probe at 9 degrees into transverse, and then I just go proximally from there. So this is a video of that. I'm now in transverse, and my IT band is here. My greater trochanter is here, and I'm moving proximally. You'll see how new structures and our IT band is moving more superficial up here. So it's again here. And it keeps moving, 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 becoming a lot more superficial. And that's moving proximally towards the iliac crest. Okay. So now that I followed the IT band all the way up in transverse axis, right now this image is just below the iliac crest. So from here, I basically rotate the probe again at 9 degrees, and then I'm going to catch my iliac crest and then the IT band coming off of that. So this is transverse. My IT band is up here. And you'll see me turn. So here's our iliac crest. Here's our IT band there. And our muscular structures underneath. All right. So in terms of this patient, the ultrasound report, like I mentioned, overall, everything was normal except that fluid distension of the bursa, the trochanteric bursa. So fluid distension of the greater trochanteric subgluteus maximus bursa, which is compatible with greater trochanteric bursitis, otherwise normal sonographic examination of her lateral hip. And that's everything I got for you guys.
All right, thank you for that great presentation. It was a very good overall protocolized scan with holistic evaluation of the lateral hip, which again comes up commonly in clinic. A couple comments that I have. I really like how you emphasized evaluating the gluteus medius tendon, both laterally and then that posterior, superposterior facet, as there is a decent amount of probe manipulation and orientation that needs to take place to get the full breadth of the tendon, both in short axis and long axis. And then the other comment that I'll have is from the bursal perspective. Obviously, in that case, we do need to use very light probe pressure. Otherwise, you're going to kind of compress that potential fluid out of the region. So I also will try to prove that it is truly a bursal collection by using that light probe pressure initially, and then also using a little bit of compressibility or pressure, because any bursal collection or most bursal collections, unless they're complex, are going to be compressible. So just a couple other points. Um,
Absolutely. Thank you.
let's go ahead and open it up for additional discussion.
Yeah, hi, this is Doug Hoffman. Great presentation,
Thank you.
images and ultrasound images as well. Just a couple anatomic clarifications. So my understanding is that the anterior facet is the G-min, and the fibers of the G gluteus minimus. Lateral facet is the fibers of the anterior band of the gluteus medius. The superior posterior facet would be the posterior band of the gluteus medius. And there's really no tendinous attachment onto the posterior facet, but just the overlying greater trochanteric bursa. Um, and so I just refer to Fehrman's article from 2001 and radiology, where he did anatomic studies and really nicely kind of outlined that. And that's been an important article for me. So just for clarification, um, because there really is no attachment to the true posterior facet of the greater trochanter. Um, my protocol when we do a lot of lateral hips in my practice, probably a couple a day. And our protocol always starts with the anterior hip. And the reason is I have found in about 5 to 10% of people with hip OA, they have lateral hip pain. And they actually are tender laterally. But if you were to inject into the bursa, they would just get partial temporary relief. But if you inject into the hip joint, they get full relief. And so I've learned over time that there's a subset in a minority of patients with hip joint disease that have lateral hip pain. So I include a limited evaluation of the anterior hip in my lateral hip protocol. And through the years, I think that's held true just because I've found that, yeah, we missed a lot of hip arthrosis by just if we don't start with the lateral hip. Conversely, for my anterior hip protocol, I will often include the G-min because the G-min is the anterior hip structure. And I have early on missed G-min pathology by not including that in my anterior protocol. Um, I think probably one of the most important images in your talk was when you showed that short axis of the um, greater trochanter, and first showed the G-min, and then you went over to the G-med over the lateral facet, and then you rotated your probe. So you nicely demonstrated there that it was oblique on the short axis of the anterior band of the G-med. And then you rotated the probe where the posterior aspect of the probe was rotated cephalad. And then you nicely cleaned up that G-med into a beautiful image. And I think that was really important because this is all about angles. And exactly. And so when you take your probe like you did and you rotate it to clean up that G med, and then you look down at your probe, that is the angles that you want. And so you've now demonstrated really nicely the optimal long and short axis, not only of the anterior band of the G med, but that translates over to the G min because those angles are very similar. Um, and so you can use that sort of because that angle will change depending on how much hip flexion they have in the fetal position because they're in the fetal position when they're side lying, no one side lies straight. And the more acute that angle is when they're in the fetal position, the more rotation of the probe. So that was really nicely demonstrated. A couple of tips that I have found over the years really helpful in evaluating the G-min and G-med is to increase my depth. And so I usually start out by a fair amount of depth so I see the full tendon and muscle. And that helps me for a couple of reasons. One is it helps me to find that optimal orientation because particularly on the G-min, I can sort of align that um, superficial border with the muscle of the G-med nicely with a subtle probe rotation, so I know I'm on the long axis. The second reason, and then on the G-mid anterior band, I can see that central tendon really well, again, rotating on it to optimize that G-med anterior band image. Secondly, is oftentimes pathology starts at the myotendinous junction and not actually at the insertion of the tendon on the facet. So for the G-med anterior band, it inserts on the posterior aspect of the lateral facet, but the pathology starts more at the cephalad portion of the facet itself, an undersurface rubbing. And so when I start out, I often have increased depth, see the whole myotendinous junction, and then if I need to decrease the depth and hone in on the tendons for more detail. I've just found that over time a useful trick to do. This is patient is interesting because in my experience, it's unusual to have fluid in the bursa without G-mead or G-min pathology. Probably speaking to the fact that she was younger,
Mhm.
athletic, and that's been true in my experience as well. Is when I see isolated, let's say G-min tendinosis, a true tendinosis that's not attritional, which is 90% of what we see is attritional changes, but let's say a thick G-min tendon or a thick posterior band of the G-me tendon. Those are usually athletic related. And in this case, that's exactly the analogy here is that this was an athletic person, relatively young, who then developed pain, fluid to give a bursopathy. So, but the majority of cases that you're going to see on this um, are going to be attritional type chairs, and the bursal changes will just be a part of those attritional changes of either the G-min, G-med, or both tendons. Um, so those are just the comments I have. Nice presentation.
Thank you. And thank you so much for those pearls. Really appreciate those. Those are very helpful.
I just had a kind of just a point and kind of more of a question. One thing that I think we kind of I guess, under realize or, sometimes forget is that, some of the posterior gluteal musculature and those external rotators attached to that greater trochanter. And I just didn't know from anyone's experience, on the call and, scanning this area, is that something that you ever add into your protocol at looking at the attachment of the like piriformis or obturators, to that greater trochanter? And is it something that you've ever seen, pathology with? And is it something that we should be adding to this protocol and, potentially something that, we're missing if we're not including it?
For me, no, I don't. But I think Dr. Hoffman has a lot more experience than I do. I'm not sure if he wanted to speak to that.
Steve, that's a good thought. Probably the most common, I would say, greater troch pathology that I see, even though it's not common, is a tear of the Gmax and its interface with the IT band. And it's something often we don't think about and missed. Um, and so, yeah, I mean, I usually don't venture into the sort of the, deep gluteal space unless I think that the pain, could be arising from there. It's interesting that the piriformis is right next to the G-min, and you wouldn't think of that. You would think the G-min is an anterior structure, but it's a very broad, deep structure, and then it abuts the piriformis tendon, where the piriformis attaches on at the posterior aspect of the greater trochanter. So, yeah, I mean, I occasionally will venture there. It typically is not part of my regular protocol unless the clinical situation dictates that. Has your experience been different or?
No, yeah, no, yeah, I haven't, picked up on too much, pathology at the area. I just always started to be curious though, as to why those tendons attaching onto the greater trochanter never end up seeming to be having any significant pathology at that area, where it just seems so common with the gluteal tendons. And obviously that may be, just the biomechanics, but it just, made me start to be curious as, starting to look at that, and is there more pathology that we're just, not realizing, within those structures that might be contributing to some of this pain, especially maybe in a patient, like you said, that, comes back that they don't have any glute med, pathology or glute min pathology, at that area, but still have, the classic presentation for greater trochanteric pain syndrome.
Yeah, and it's interesting because a lot of our patients are older population, and I think it's the lack of core support, and they almost walk more in a Trendelenburg, a very subtle Trendelenburg gait, and that puts that pressure on the G-min and med more than it does the posterior fibers. But it does bring up an interesting point, and that point is that the greater trochanteric bursa is a posterior structure. And oftentimes, and I don't know in this patient, but you know, it's not unusual when I see, let's say, full thickness tear and they got bursal fluid, which now communicates with the sub G min bursa. It's posterior. And so if you don't look posterior, you may miss that. Was this patient having more posterior pain or lateral pain?
It's like posterior lateral.
Uh-huh. Yeah. And so again, Steve, Stephen, to your point, I mean, even symptoms arising from the greater choke bursa often can be posterior lateral pain. And I've seen a number of patients who come in and they've asked us to take a look at the deep gluteal space, and what they have is a tear of most commonly the G med anterior band, fluid in the greater choke bursa that now is basically located posteriorly.
Yeah, and Doug, I mean, I would completely agree with the point that you made earlier too about referral pain from the hip joint, especially. And so obviously in this patient, I think it's always prudent to, get x-rays like you did as well too. But then as you had mentioned, doing a scan of the area, because I think so many of these patients present, as you had mentioned, with that posterior lateral hip pain, and you just, you don't realize when then boom, you're scanning over that area, especially that gluteal space, what is sitting right underneath that piriformis is that posterior hip joint. And, I think studies have shown that the hip pain can refer as commonly anteriorly, that quote unquote classic anterior, thigh pain and groin pain, actually posteriorly, as well too for a lot of these patients. And they seem like they're tender over that posterior portion of the greater trochanteric bursa, but then just realizing very close to that area too is that posterior hip joint. So just having that in the differential, I'd completely agree with it.
Yeah, good point. And when I see, when I am asked to scan a lateral hip, let's say a patient like the one you presented, I'm definitely, my radar is going up for different things rather than the typical sort of attritional changes we see, as we age. I'm looking very closely at the posterior band and, the G min. These are isolated tendinoses that we just see more in the younger athletic population that we don't see in the very common sort of attritional type, pathology. There was a comment, my clinical practice, most patients have a very vague description of the location of pain. I feel more comfortable assessing both clinically and sonographic the anterior lateral and posterior hip structured. It is, in my view, inadequate to sonically evaluate lateral hip only, anterior only structures. I would appreciate the panel's view on this. Yeah, and I think that's kind of what we're addressing here. That's a good comment that um, you know, this can be a very difficult area to evaluate. There's this hip pain because, as we've all mentioned, you can get referred pain. And so I think the point is that, by sort of thinking about scanning anterior lateral posterior hip, or at least that possibility, you may have more complete evaluation and are less likely to miss pathology that is referred pain at a different location. Yeah, that's a good point.
All right. Well, thanks again, Dr. Bouchereau-Lal, for the great presentation and obviously the good discussion to follow this up with. So we appreciate you being here.
Thank you so much. I
Um,
appreciate all of you too.
just an FYI, for next month, we will be doing a case on adhesive capsulitis. So look forward to that as well. Thank you all.